there's a lot of background noise. I apologize for that. We will also have a Q&A session after Morten has presented his research. So if you have any questions, you can use the chat box and also just unmute yourself and then ask your questions. Here you go, Morten. I'll leave it to you.
Thank you. So the talk today will be about bone and the emerging incretin-based treatments of type 2 diabetes and obesity. I'm a clinical doctor, so I do research. The molecular endocrinology suggests that I do molecular biology, but only to some degree. I'm mainly a clinician. And I also have to say that I'm an expert in bone disease. I don't treat type 2 diabetes, nor do I treat obesity. But this is an area that has attracted a lot of attention recently, and with a whole bunch of new drugs on the market and emerging, and some of them may have adverse effect and some may actually have beneficial effect to bone, which I think we really need to be aware of. And I think some of the mechanisms in play need new techniques like imaging, spatial transcriptomics, and other methods to really understand what happens in bone. So I think this is a topic which is relevant, but also something that could be relevant to this specific organization, the ISBM. Anyway, so I should start by saying that I have conflicts of interest. I've received investigational drug from Novo Nordisk to run a project that I'll present later on today. And in my retirement, I also have stocks in Novo Nordisk and Eli Lilly, and probably other pharmaceutical companies that I don't know of, but now it's mentioned at least. So the starting point of the talk today is the gut and bone. There are numerous studies showing that there's a kind of connection between the gut and bone. This is one of the early ones where Nina Bjarnason demonstrated that during sort of a normal diet, you see a significant change in CTX, bone resorption marker CTX, something which is quite dramatic and not really as dramatic as sort of expected. There's a very significant reduction in CTX. A similar reduction is seen with oral glucose, but not with IV glucose. So the changes are not really explained by energy intake. And interestingly, there's no change in osteocalcin with food intake or oral glucose intake. The group in Sheffield, headed by Richard Estelle, then used octreotide, a drug that is blunting the secretion of gut hormones like insulin, glucagon, and the hormones I'm going to talk about today. And then they offered a nice drink with glucose and show that when you prevent secretion of the gut hormones, you don't see this change in CTX levels following glucose intake. Here, the investigators show a mild decrease in bone formation marker P1 and P, but as you can see, the change is not even close to what is seen with CTX. So food intake mainly drives resorption, not formation. And in an elegant study, Jens Holst from Copenhagen studied people that have gone through surgical procedures to remove certain sections of the gut or had ischemic events in the gut. And these patients with short bowel syndrome that cause a lot of different adverse effects, and here they investigate the effect of food intake on bone resorption on the left side and formation on the right side. As you can see, there's no effect of food intake in bone formation marker osteocalcin, but looking at CTX levels, the investigators could demonstrate that in the normal individuals, there was this well-known reduction in CTX, whilst those who had shorter or longer sections of the gut in place, they had lower responses, or actually no response in those with both short bowel syndrome and without colon. So this provided further evidence of a link between mechanisms arising in the gut and bone resorption. So this suggests that there's a link between what is secreted in the gut and bone remodeling, and something that happens quite quickly with food intake. It could be direct through insulin secretion. Insulin is suggested to act on bone, or it could be other hormones arising by or during the insulin secretion. With insulin comes also amylin, which is anti-resorptive to some degree, and there's also glucagon, of course, secreted from the pancreas. But these hormones may also have direct effect on bone, which I will talk about in just a few seconds. These hormones are secreted from specific areas of the gut. Some overlap, but in rather sort of anatomically different sections. And they're secreted along with other hormones. So for instance, GLP-1 is secreted along with GLP-2, which does have bone effect, as I'll talk about later on. So here's a picture of one of my brilliant colleagues, Nina. In her project, she has recruited healthy men, young men, and then we collected a bone marrow aspirate before doing any of the experiments. After that, we titrated glucose to a level of about 8 to mimic what happens after food intake. And then we started infusions of either GIP, GLP-1, or a combination of those two hormones. And as you can see, CTX levels drop quite quickly after initiation of the infusion. Whereas if you infuse GIP, you see this transient but fairly small increase in bone formation marker P1 and P. It looks like something that could be an error, but has been shown in other projects. Now, the main thing here was to actually look at what happens in the bone marrow. So after the baseline bone marrow aspirate, we also collected bone marrow aspirates after either GLP-1, GIP, or the combo infusion. So all in all, 4 bone marrow aspirates in all the participants. And here you can see that the levels of CTX was very, very much decreased by both GLP-1 and GIP and the combination, suggesting that they all have an effect on bone resorption. And it may be that there's also an effect on bone formation, at least measured by P1 and P. As we can see that after 2 hours, there seemed to be an increase in level of P1 and P. But of course, who knows what happened between baseline and 2 hours? It may be that P1 and P has actually been a lot higher. So now we're studying metabolites, and we've also looked at bone marrow cells from these individuals. But this is just to show that what is seen in circulation seems to be also reflecting what happens in the bone marrow. So what are the skeletal effects of GIP then? There's quite a lot of studies of the effect of GIP on bone. This is one of the first studies where the investigators looked at mice without the GIP receptor. And in these mice, they could see a mild phenotype, somewhat smaller mice, but somewhat also smaller bone marrow density, suggesting that action through this receptor is important for bone mass. The same group then overexpressed GIP and demonstrated that with overexpression, you do see an increase in bone marrow density, and that was reflected in an increase in bone formation marker osteocalcin and a reduction in bone resorption marker. So this further provides evidence that GIP is important for bone with a receptor. If abolished, then causes a reduction in bone mass and overexpression leading to higher bone mass. So the group in Angers in France has studied the effect of these gut-secreted hormones for many years and have provided some very interesting data that I will share with you by the end of this talk. But one of the studies showed that if you add GIP to cells that are differentiating into osteoclast, you do see a reduction in the formation of TRPC positive cells, at least with human cells, suggesting that GIP acts on the differentiation of the osteoclast. So here's another photo, and this is another member of our group, Morten. And he studied together with Kent Sø the effect of GIP on human osteoclast. So in this study, we collected monocytes from healthy individuals and differentiated them into osteoclast and did RNA-seq at different time points during differentiation. And we can see that the GIP receptor is expressed during differentiation with an increase, particularly after 6 or at day 6 and 10. And we can see that the receptors is also to be found in the osteoclast in femoral bone. And to further provide evidence of a real effect, we can also see that that GIP added to osteoclast has an effect on bone resorption, reduces resorption, but the antagonist blunts the effect. So it seemed that GIP, at least in culture, has anti-resorptive effect. In a much more sort of elaborate study, the Angers group has investigated the effect of a number of different gut-secreted hormones on bone. And I just wanted to include this study where they have looked at the effect of lack of GIP on different mechanical properties of bone, including maturation of collagen. And interestingly, they do see a significant change in bone material properties, suggesting that the overall effect of GIP may not be obvious when only assessing bone density, but rather one needs to look into the properties of bone. So what are the clinical evidence of an effect of GIP on bone? This is a fairly old-ish study where the investigators looked at a Danish cohort of women who had been followed for 16 years, and they looked at a specific genetic variant in the GIP receptor, presumably loss of function receptor, or variant, sorry. And they could see that those carrying the variant who were homozygous for the variant actually had lower bone density of the hip, and also a higher risk of non-vertebral fracture. And this was in a study of some 2,500 individuals followed for quite a long time. But then what often happens in genetics is that larger studies are published, and this is a fairly recent one from December 2023, showing that in fact in a much larger cohort, this specific gene variant was not associated with higher fracture risk or bone mineral density, might even have a protective effect. So it's not really clear from genetics if variants in the GIP receptor has a deleterious effect. It seems not perhaps to be the case. There are, to my knowledge, only this study of sort of longer time exposure of healthy people to GIP. This is a study where the investigators looked at type 1 diabetic individuals and infused GIP using an insulin pump. And they could see that the resorption marker CTX was reduced during the first hours, up to 180 minutes. But then on day one, bone resorption was actually the same. During this time, the pump had been going continuously. So it may seem that actually a continuous exposure to GIP, at least native GIP, doesn't really change bone turnover. We thought it would be anti-resorptive, or at least keep CTX at a low level, but it seems that it may not be the case. So perhaps we need to look further into this. And one reason for this lack of change in CTX may be, and I do say maybe because we don't have a lot of evidence, but it may be that the receptor is desensitized due to long-term exposure, as has been shown in this fairly recent study where cells were treated with GIP, and then the investigator looked at CMP levels after GIP exposure and could see that the effect was actually blunted by long-term pre-treatment with GIP. Interestingly, from a pharmaceutical point of view, I guess the GIP agonist and GIP antagonist seem to work equally well. Here, mouse GIP receptor antibodies are used alongside with liraglutide, a GLP-1 receptor agonist, and compared to long-acting GIP agonist and liraglutide. And there's kind of the same effect on weight in mice that are being overfed with fat, suggesting that whether it's an agonist or antagonist, you might end up with the same effect, possibly because the receptor stops signaling. So this might have an effect on bone if we start using GIP in clinic. So I think from a bone perspective, it would be interesting to know if continuous stimulation of the receptor actually blunts the anti-resorptive effect of GIP, which seems to be the case, or it may be the case based on receptor signaling studies, but we don't know from clinical data yet. So At this time, as far as I know, there's just one drug on the market that that includes effect on the GIP receptor, and that's tirzepatide, which is marketed by Eli Lilly, sold as Mounjaro in the US, and Zepbound, used for type 2 diabetes and obesity. It's modeled on human GIP, but it also acts on the GLP-1 receptor. And it causes quite a dramatic reduction in glucose levels. So therefore, it's effective as a treatment of type 2 diabetes. It acts both on the GIP receptor and it acts on the GLP-1 receptor. And it does have long-term effect, suggesting that it may be that perhaps in bone, GIP has a transient effect, but at least when it comes to the islet, then it may be that things are quite different. So perhaps tirzepatide will have bone effects, perhaps not. To the best of my knowledge, we don't really know at this time. So at least when I looked at the pivotal trials, there were no major sort of mentioning of fractures as an adverse effect in those studies. Then comes GLP-1. So we saw that GLP-1 infusion decreased bone resorption measured as CTX. But the question then is the receptor actually expressed in human osteoclast? And just 1 day ago, Morten and one of my colleagues, Alex, paper came out in this journal, Bone Research. And here we looked at osteoclast during differentiation, as I talked about earlier on, and identified a number of different clusters that showed up during differentiation. And to my surprise, neither of them includes the GLP-1 receptor. The fourth cluster here includes the GIP receptor, but GLP-1 receptor doesn't show up. And this is done on plastic, and we actually repeated it on bone cells with RNA-seq, and we couldn't see the receptor. So there we are. We haven't found receptor, but it seems that there's a kind of effect. There are a number of studies that have looked at expression of the receptor, and some have shown that it is expressed in osteoblastic cell lines. Some have shown that it's not. Some have shown that it's expressed in human mesenchymal stem cells as well. It seems to be not really set in stone if it's true or not. However, there is a nice number of studies showing that GLP-1 does have an effect on bone. It may be it's a direct effect or maybe an indirect effect. So in this study, the investigators looked at the GLP-1 receptor and the relevance to a number of different bone-related outcomes, including total bone mineral density and different mechanical properties of bone. And they could see that if GLP-1 is lacking, then you would have an impairment of bone mass and also mechanical properties. And interestingly, they found an increased number of osteoclast as well. Importantly, in rodents, but not humans, GLP-1 leads to the stimulation and secretion of calcitonin, which has anti-resorptive effect. So it may be that these outcomes are merely reflecting a lack of calcitonin. Yeah, that's where we are with that. But there are other studies that have looked not at GLP-1, but rather GLP-1 receptor agonist like liraglutide, which still is commonly used. And they've shown that liraglutide has beneficial effect on bone in a number of different animal models, including OVX-induced bone loss in rats, and also in glucocorticoid-induced osteoporosis, or bone changes in bone formation and resorption. And I know font size is not kind, but as you can see down here, bone formation marker is reduced by dexamethasone as expected, and that deleterious effect on formation seems to be removed by adding liraglutide. So some indications that liraglutide might be beneficial in in mice or rats rather, and that it increases bone formation. This is just 2 studies. There are other studies showing the same direction of effect. Then a more recent study where the investigator looked at Incretin 4, GLP-1 receptor agonist, and they demonstrated that if you extract MSCs from a bone marrow and treat them with Incretin 4 quite quickly after extraction, then you do see that this GLP-1 based compound promotes osteoblast differentiation. But if you add it to a differentiated osteoblast, don't see an effect. So it may be that it helps with differentiation of osteoblast. We also looked at osteoblast and osteoclast in using human cells and using both single and co-cultures. And we do see quite different effect of GIP and GLP-1. I should say that these have not gone through peer review, so a pinch of salt might be just needed. But anyway, so in this study, we added GIP or GLP-1, and we also used semaglutide, a GLP-1 receptor agonist, commonly used. So the data are sort of the same for GLP-1 and semaglutide. And this study, we saw that when we add GLP-1 to osteoclast, there's an increase in activity. And in contrast, GIP decreases the activity. And in co-cultures with osteoblast, we also see that that in the co-cultures, osteoblasts' activity are increased in the semaglutide treated cultures. When we use bone lining cells, we don't see an effect of GLP-1 or semaglutide. And when we use osteoblasts derived from MSCs, we do see an effect directly on the osteoblast. So it may be that GIP and GLP-1 have differential effects on bone cells, with GLP-1 potentially increasing activity, GIP doing the opposite, and also that these hormones having differential effect on bone formation, which could have a clinical implication as well. But what are the at this time known effect of GLP-1 from studies of humans, real clinical data? Actually, there's not a lot. So these compounds, GLP-1 based compounds, are used extensively in type 2 diabetes, which, as you know, is associated with an increased risk of both non-vertebral and vertebral fractures, as shown in this meta-analysis from Tatiana Vilaka in Sheffield. We also know that hyperglycemia inhibits osteoblast maturation and decreases bone formation. So using a compound that is effective in reducing glucose alone would improve bone formation, one would expect. But as the animal model suggests, there could also be a beneficial effect on bone formation. So Bente Langdal in Aarhus investigated the effect of liraglutide or Victoza, half a year of treatment of that in doses used to treat type 2 diabetes. And in this study, they observed almost no effect on bone turnover or bone mineral density, despite the fact that there was a small but significant decrease in body weight. These drugs do cause weight reduction, of course. So it seemed that bone mass was, at least to some degree, maintained despite of the loss of body weight, indicating a potential beneficial effect on bone. But bone turnover markers were not really showing any direction. At this time, we have registry data and meta-analysis of clinical trials showing neutral or perhaps even beneficial effect of early GLP-1 receptor agonist, but the more later introduced GLP-1 receptor agonists are not really included in the registry data, and they are a lot more potent when it comes to body weight. So it may be that in fact things are different, but at this time point there doesn't seem to be a deleterious effect. So we played with the idea that actually GLP-1 would increase bone formation, and again Morten was during his PhD engaged in this project where we randomized men and women with T-score of less than -1 without type 2 diabetes to semaglutide 1 milligram a week or matching placebo. We thought that P1NP would increase because the animal model suggests an increased bone formation. But as you can see on these two graphs, CTX increased quite dramatically, whereas P1NP didn't really change at least not really significantly, but we did see an increase in CTX. So based on these data, we're not really convinced that P1NP should have any beneficial effect on bone formation. And mind you, these are people without type 2 diabetes, so it means that they don't have a low bone turnover when exposed to the drug the first time. These are supposed to have normal bone turnover. So no increase in bone formation. And what we also saw was that, at least in typical volumetric bone mineral density assessed with HRPQCT, there was a change in bone mass, and we also saw with DEXA a change in total hip and lumbar spine bone mineral density during that 1 year of treatment. But of course, there's one caveat, and that is the fact that semaglutide is a drug that has this oftentimes beneficial adverse effect, namely a reduction in body weight. And we did see about 9% reduction in body weight during this 1 year. As you can see, the weight reduction is most pronounced in the first half year, and then sort of levels off and isn't really different between week 39 and 52. But actually, bone resorption markers seem to increase after week 39. But whether that levels off as body weight stabilizes, we don't know. So we do know, however, that weight loss generally is associated with bone loss. And there are a couple of very good studies here. I've just included 2. But in this study, the investigators aim for 25% calorie reduction in men and women aged 20 to 50. They provided nutritional and behavioral guidance, but not exercise guidance. And this study, the participant lost about 9% weight, similar to what we saw before in our study. And they also lost bone mass, both at the hip and spine, as in our study. So it may be that what we see is similar effect, whether it's a semaglutide-induced weight reduction or it's induced by calorie restriction. And here we have the bone resorption markers. As you can see, CTX increases quite a lot and then levels off, which is a bit different to what we saw. We mainly saw a late onset of increase in CTX, but at least it's the same pattern. Again, with P1NP not really following the CTX level. More recently, some of the same investigators tried to then add a bit of sort of color to this story. So again, they looked at the effect of weight reduction on bone and bone turnover. And in this study, they then, besides achieving the weight reduction, they also added either aerobic resistance or combination of exercise. And what might not be obvious due to the font size is that aerobic exercise doesn't really do any good to the changes in bone resorption. So you do see with a weight reduction increase in CTX on aerobic exercise. By contrast, resistance training seemed to have a good effect on CTX, at least keeping it a lot lower and similar to almost as low as the control group, suggesting that the resistant training would actually be beneficial when it comes to bone turnover. And as you can see on the left side, the aerobic training didn't really have any significant beneficial effect on bone mineral density. By contrast, the resistance training seemed to do fairly good when it comes to maintaining bone mass. So perhaps resistance training is something that needs to be added in the context of weight loss, at least in people who might be at risk of developing osteoporosis or who actually have osteoporosis. So, but of course, the drugs used to treat type 2 diabetes are also used to only treat obesity, usually in a lot higher doses. This is just one example of these studies with semaglutide, the compound we used, albeit in a substantially higher dose. In this study, the investigators treated participants for 2 years, and as you can see, again, there seems to be stabilization of body weight after approximately 1 year. We don't know if these changes lead to dramatic changes in bone mass, but we do know that there's an effect on lean body mass. So it may be that we can see a significant reduction in bone mass, and it would be interesting, I think, for the future to know if that change in bone mass is stabilized as well, or whether it continues after the body weight has stabilized, as I think seen in bariatric surgery. But this is an area with a lot of attention, loads of money to be earned in this field of medicine, and a lot of new compounds emerging as well. Some may have a similar effect on bone. Some may have potentially slightly beneficial effect on bone. Again, tirzepatide, as I mentioned before, in somewhat higher doses, it may cause something around 20% reduction in body weight, quite substantial changes to body weight. And in another compound in clinical trials, we don't know if it's ever going to hit the market. The investigators combined semaglutide with cagrilintide, which is a non-selective amylin and calcitonin receptor agonist, and very at this time old-ish studies suggested that amylin might have inhibitory effect of osteocalcin and on osteoclast, sorry, and of course calcitonin has the same. So amylin acts on an amylin receptor, which is a calcitonin receptor with some modification. So it may be that some of the future obesity treatments may be beneficial to bone or have less deleterious effect on bone. We don't know. So I just want to add one case from my outpatient clinic, a case I've seen in different variations several times now. And this is just one example. So a 65-year-old woman with osteoporosis, established osteoporosis. She's been on alendronate, but was stopped because T-scores had improved quite nicely, and she didn't seem to be at high risk of fracture. She's active and non-smoker, so successful so far. And then she returns for a new DEXA after 2 years, and we see that lumbar spine T-scores are the same, but there's an 80% reduction in total hip bone mineral density. And of course, that's quite disturbing. So we go through all sorts of biochemical tests, check her medical history, recheck to make sure that there isn't anything we've missed. And perhaps I have missed something, I don't know. But in this case, the only reason I could find for this change in bone mineral density was a 20% reduction in body weight. I've had similar in people also treated with zoledronic acid, but the question is, will this lead to any sort of concerns that should change clinical practice, or is this something we have to consider when we see significant changes in BMD despite treatment? Can these treatments actually protect from bone loss? So a couple of questions remains to be dealt with. I think we do see sort of an uncoupling of formation and resorption, which I think is something where your organization could really help us understanding the mechanism, and perhaps lead us to not only better understanding, but also better options of preventing bone loss. It may be that what we look at is simply just a calibration of bone mass to fit a body that has a lower weight. We know that resistance training seems to decrease bone loss, which is something that we might consider in the future, at least in people who are at high risk of developing osteoporosis, who may have established osteoporosis. And it also seems prudent to investigate if available fracture preventive pharmaceuticals are actually effective in alleviating the bone loss, at least to some degree, during these rather dramatic weight losses. So we know that gastric bypass, ORE gastric bypass, leads to an increased fracture risk, quite dramatic increase, something that increases the longer as we move away from the timing of the operation. We have zero knowledge of this being relevant to the obesity treatments available at this time. However, there's one thing that is very different when one compares bariatric surgery to the new treatments of type 2 diabetes and obesity. and that's the effect of bariatric surgery on hormone secretion. For those who like hormones, this is really, I mean, that's really something that may be beneficial to the patient, but it's really an oddity when it comes to the secretion of the gut hormones. In this study, the investigators from the Copenhagen area have compared the secretion of GIP in controls and after gastric bypass, and they do see significant changes. The same goes for GLP-1, which I think is quite obvious. So in the Hawaii gastric bypass operated patients, you do see a very dramatic increase after glucose intake, but this is not really the case in the controls. And that goes mainly for those two hormones, but there are other hormones like PYY that sees a very different pattern, and which could all have implications for bone turnover. Because in this case, bariatric surgery, there are other things in play, for instance, malabsorption, lack of macronutrients, etc. So this is quite something different and something that probably cannot really be compared to the pharmaceuticals. But could any of these gut hormones actually be used as a treatment of bone disease? That's something that could be interesting. And early on in 2009, investigators from the Copenhagen area used GLP-2, which is co-secreted with GLP-1, treated postmenopausal women for 4 months with the hormone, and they observed that the hormones actually had a very good effect on reducing CTX, and that it also increased bone mineral density, at least at total hip bone mineral density. So GLP-1 seemed to have an anti-resorptive effect. And very recently, the group from Angers published a paper where they've looked at a very intriguing molecule, a GLP-2 anti-resorptive and GIP anti-resorptive dual agonist or analog, and which seem to have effect on bone, but in particular the mechanical properties of bone. So I think this is a new sort of way of potentially treating bone disease by using these hormones to perhaps not increase bone mineral density, but rather change the quality of or mechanical properties, at least, of the bone. So a very interesting paper. But there are, of course, other compounds that are being developed for other conditions that might potentially be repurposed as treatment of bone disease, or which might be relevant to people with, for instance, type 2 diabetes or obesity, and osteoporosis, or risk factors that predispose them to developing osteoporosis or fragility fractures. And this was one compound I discovered recently, dapiglutide. I don't really know it, but it's a combination of GLP-1 agonist and a GLP-2 agonist. So this dual receptor agonist could actually have beneficial effect on glucose regulation and potentially also on bone resorption. The intriguing part about GLP-2, it seems, is that it also regulates inflammation. So it could have a very sort of a different effect on whole body energy metabolism. So this